Hi, my name is Jess, and I'm a Maryville nurse practitioner student. This is my husband, Andrew, and he's going to be helping me today as my patient for my head-to-toe nursing assessment.
I, Andrew, voluntarily give Maryville University permission to record my image and/or voice, and grant Maryville University our rights to use this recording in any medium for educational or other purposes that support the mission of the university. I understand the following information will be gathered by Maryville University students as part of a course assignment. I give my express consent for information gathering and physical assessment to be filmed and posted in students' course show for access by faculty and students at Maryville University. I further acknowledge that since the recording is for educational purposes only and the information is not meant to be diagnostic, therefore, Maryville University, the faculty, staff, and students are not considered liable. The recording will be deleted by the student and any other devices as soon as it's been reviewed and graded by the instructor.
Perfect, let's get started. So I'm going to start with the head. So I'm going to come in, just notice the overall contour, the shape. Looking at the hair growing nicely, it's thick, all growing in the same directions. I'm just going to palpate. Any tenderness?
No.
Good, I'm not noticing any masses, no irregularities. And next I'm going to move on to the eyes. Again, I'm just examining, I'm noticing that the sclera is white, pupils are equal. I'm going to have you look up. Conjunctiva is pink, and he's able to follow things with his eye movements. I'm first going to test cranial nerve number 2. This is testing vision. I'm going to stand 6 feet away and have you read the smallest line you can read.
All right, LTFPH.
Okay, and I would have you do that with one of your eyes closed and then the other. That was 20/20, so he sees at 20 feet what the average person sees at 20 feet. Very good. So next I'm going to come in and just test fields of gaze. I'm going to have you follow my pen light. Good, and that just tests his eyes were able to follow it. There was no lid lag, there was no nystagmus, and he was able to follow them with both eyes. He was able to test for accommodation, so his pupils constricted when the light got closer. So next I'm going to test pupillary constriction. Direct and consensual. Good. Direct and consensual. So that was doing well. In the fields of gaze, we'll test cranial nerve 3, 4, and 6. I'm also going to test peripheral vision. So close your right eye and tell me when you can see my fingers.
Yep. Yep. Yep.
Good. So assuming my peripheral vision is good, which it is, and he saw my fingers at the same time I did, so I assume that his is good as well. So next I'm going to look at the inner eye structures. So first I'm going to check the red reflex. All right. Go and look straight ahead. Good. A little closer. Look at the inner structures. The optic disc and the blood vessels look good. All right. And I would do that with the other eye as well. All right, so next we're going to move on to the ears. Again, examining first, noticing that they're both symmetrical. There's no redness, no foreign bodies, no discharge that I've noted. I can also test cranial nerve 8. So I would do this by having you stand up. And I'm going to stay about one, going to face that way. Be one arm length away. I'm going to say a 2-syllable word, and you can repeat it.
Golden. Husky.
Good, and he was able to hear that and repeat it back, testing his cranial nerve number 8. I could also, you can go and take a seat. I can also test his hearing, inductive and sensorineural, using the rubber and rhyme test, but we're not going to do that one at this time. So next I'm going to look at the inner ear structures. We pull up and back. All right, a little bit of cerumen, but the tympanic membrane is white. I don't see any redness, no bulging. All right, next I'm going to move on to the nose. I'm just gonna, again, examining that it's midline, no trauma. I'm gonna check for patency. Just close one side and blow. Good, and the other side. Good, so I know that it's patent. I can test cranial nerve number 1 by doing the smell test. I would close off one side and have him identify a familiar smell, and I would do the same with the other side. It's not commonly tested, but that's how that would be done. Next, I'm going to look inside. Changing my scope. Look. Good. Turbinates look good. It's very pink, moist. No congestion, no redness. And next I'm going to move on to the face and the mouth. I'm going to have you open your jaw. Good, and close, open, close. Good, and that's testing cranial nerve number 5. This jaw is very strong. It's very equal, which is a good finding. I can also do checking cranial nerve number 5. I could use the soft and sharp touch. I can have you close your eyes, tell me if it's sharp or soft.
Soft. Sharp.
Good, and that'd be cranial nerve number 5. So I'm going to look inside the mouth, go to the ah. Good. Down, side, go up. Good. And that's testing cranial nerve number 9 and 10. I'm also looking for any lesions, any sores, any plaques that might indicate oral cancer. Looking at the rise of the hard and soft palate, test cranial nerve number 9 and 10. I could also elicit the gag reflex, which would also test that. All right, and cranial nerve number 12, I'm going to have you stick out your tongue, move side to side, up and down. Good, and that tests cranial nerve number 12. Cranial nerve number 11, maybe you shrug your shoulders. Good, and that's they're both equal, it's strong, testing cranial nerve number 12. So next I'm just going to check for lymph nodes, preauricular, postauricular, occipital, cervical chain, submental, submandibular. Good, and then axillary, then epitrochlear. Okay, good. And they weren't palpable, but if they would be soft, non-tender, that'd be a good finding. So from here, I am going to move on to the cardiac. So for this, I'm going to have you take your shirt off. And if it was women, I would try to provide privacy, maybe just have them lift up their shirt. All right, so first I'm going to do with the lungs. I'm just inspecting, noticing that there's no accessory muscle use, no retractions. He's breathing at a normal rate, which is good. So next I'm going to move on to palpation. I'm going to try to keep my hands warm. So I'm just palpating. I'm also noticing there's no scarring. All right, no masses, no tenderness. I'm going to have you say 99.
99. 99.
Good. Maybe move face that way a little bit. A little harder with that exam table. Again, palpating. Say 99.
99. 99.
Good. Now take a deep breath in. Good. And that was thoracic expansion. I was watching my hands move out symmetrically, which is a good finding. From here, I'm going to work on percussion, avoiding any of the scapula and bony prominences. I should be hearing nice resonance. And I'm also going to test for diaphragmatic excursion. So I'm going to take a deep breath in. Hold it. Okay, breathe normal. So I percuss down from where dullness met resonance, and I'm going to have you take a breath and then exhale all your air. Okay, good. So then I percuss up to where I then met dullness again, and I would mark each of those points, and I should get between about 3 to 6 centimeters. And I would do the same on the other side, and I should get about the same reading. All right, so I'm going to move to percussion on the front. Again, avoiding intercostal, or avoiding bony prominences. Should be hearing resonance. Good. So those were all good findings. So next I'm going to move on to auscultation. Listening with the diaphragm. Take a deep breath. Deep breath. Good. Good. 99.
99. 99.
Good. And deep breath. Deep breath. And one more. And deep breath. And say 99.
99. 99.
Good. And what I'm listening there is for a nice muffled sound. If it was easy to hear and very distinct 99, I could expect consolidation, and that might be a finding in like pneumonia or something that would have consolidation. All right. So from here, I'm going to move on to cardiac. I'm going to have you lie down. Good. So if I had like the head of the bed that could be at 30-degree angle, I would get down and look for jugular venous distension. I don't notice anything in this angle, but that's what I would look for. I'd put them in a 30-degree angle. From here, again, I'm just examining. I'm noticing that there's no pulsations that are visible, no scarring. Everything looks symmetrical still. I'm going to go ahead and then start palpation. Palpating the carotid arteries. Good. Good. And then the point of maximal impulse is at the left intercostal space, left fifth intercostal space, midclavicular line. So right here. Good. I'm feeling it, and I can test it with the carotid pulse. Good. And they're equal. They're both very full. Very good. Okay, so I could do percussion. There's not a whole lot that percussion will tell me. I could try to measure the size of the heart, but that's really not used anymore and not the most accurate way of doing things. So here I'm going to go on to listening. Listen with my bell. Okay, no bruise noted there. Okay, with the diaphragm, I'm going to start with aortic, pulmonic, Erb's point, tricuspid, and mitral. And I'm noticing that S1 is louder at the apex of the heart, and S2 is louder at the base of the heart. So I can go back through and listen with the bell of my stethoscope, listening to all those points again, noticing any bruise, any extra sounds. One other thing I was going to have you do is roll on your left side, and I can check for mitral stenosis. Again, at that point of maximal impulse, listening with the bell. Okay, good, no bruise are heard there. I can have you sit up with my diaphragm, have you lean forward and exhale all your air. Okay, good, and that was checking for aortic regurgitation. And have you lie back down again real quick, just checking pulses. Tracheal, radial. I could do femoral, but that's really hard to do with this clothes on. And popliteal, posterior tibial, and dorsalis pedis. Good. And I'm also, when I'm down here, I'm looking to see that his extremities, they're both warm, same temperature, hair growth on is good, pulses are good, and no edema, no signs of edema. I'm also going to note that there's one technique you can do to determine the patency of the ulnar. So I'm going to do the Allen test. I'm going to occlude both your radial and your ulnar arteries, and I'm going to have you move your hand like this 5 times. And notice that it gets white, good. And I'm going to release the ulnar nerve, and all the color should come back. And it does, so that's a good finding. So from here, I'm going to move on to the abdominal assessment. So what's a little bit different here is that I'm going to inspect as I normally would, but from there I would move on to auscultation rather than doing percussion or palpation, just because I would be stimulating maybe false bowel sounds then. So again, I know that he hasn't had any abdominal surgery, but I would be looking for any scarring, any masses, anything that's a little asymmetrical. It all looks good. I'm going to start by listening, the right lower quadrant. Good, and I can also listen to the aorta. Okay, the aorta. Then the iliac arteries, listening for any rubs or murmurs. Okay. Renal. Then the femoral. Good. I'm also listening over the liver. And the spleen for any rubs or. All right, good. From here, I'm going to go on to percussion. I should be hearing a nice timpani. There you go. And then I can roughly percuss the size of the liver. Go ahead and between intercostal spaces. And when I hear that dullness, it should be about 6 to 12 centimeters. And then for the spleen, all right, and so the spleen's not palpable, which is a pretty normal finding. So from here, I'm going to move on to palpation. So I'm going to start with light palpation, just to kind of get them used to my hands, note any tenderness. Any tenderness?
No.
Good, and then go on to deeper palpation, noting any masses, any tenderness, and no masses. All right, I can come over here and palpate the liver. Have you take a deep breath. Good. Go and breathe normal. And that would be Murphy's sign. If you had pain there, that could be a sign of cholecystitis. I'm going to come over here, palpate for the kidneys. And good. All right, so other things. So I could note that McMurden's point is right about here. I'm going to press over here and note if there's any rebound tenderness. Any pain?
No.
Good. And if you had pain there, that might be an indication of appendicitis. Other things I can do to check for appendicitis would be the psoas test. Can you raise your leg? Good. Any pain?
No.
Perfect. I'm going to have you bend your knee. Just going to move this. Any pain?
No.
Good. That's the obturator test. So both of those would be testing for appendicitis. And any pain found with those might indicate appendicitis. All right. So from here, we're going to move on to the musculoskeletal. So I'm going to start by having you can put your shirt back on. And while he does that, I'm just looking to note that his spine is straight. There's no curvatures of it, and it looks good. So in the musculoskeletal, I've already checked for the jaw. It has good range of motion. It is very strong. Next thing I'm going to move on to is the shoulders. I'll have you stay seated for this one because I don't want you to hit the fan. I'm going to have you do extend your arms in front of you, flexion, and then behind you. Okay, good. And then abduction all the way out. Good. And adduction crossing over midline. Good. So next thing I can do is check for rotator cuff injury. Okay, I might have you stand up for this. Okay. And I'm going to have you raise your hands up. Good. And I'm going to pull down. Any pain?
No.
Good. I'm going to have you controlled and move your arm, like let it fall, but in a controlled, slow motion. This is called arm drop, and it also tests for rotator cuff injury. Another one we could do is Hawkins, which I'm going to this, and rotate this way. Any pain?
No.
Good. That's another test for rotator cuff injury. Other range of motions for the shoulder, I'm going to have you do internal rotation, which is putting your arm behind your back, and then external above your head like you're brushing your hair. Good. Any pain with any of those?
No.
Great. I would have them do that with the other arm as well. Next, we're going to move on to the elbows. So I'm going to have you put your elbows in front, and then I'm going to have you just do a bicep curl, extend all the way down. Good. And then bring them up again, and I'm going to have you do it against, try to do them against my resistance. Okay, good. Bicep curl. Perfect. And then I'm going to have you do pronation, which is going to be like this, and then supination. Perfect. So next, we're going to move on to the wrists. I'm going to have you bring them down, bring your wrists towards you, and flex them away. Good. And then in, and out. Good. I'm going to have you resist my movements. Okay. Try it. Resist. Good. So next thing we're going to do is move on to the hands. Put your hands in front of you, then try to extend, and then adduct, bring them together, and then make a fist, and then extend. Good. I'm going to have you adduct your fingers again, bring them together, and then try to resist. Good. All right. Those were all good. So neurologically looking at, I can mix that in as well and note that his musculoskeletal is very good. All of them are very strong and it's very equal. So next thing I'm going to do is start checking the lower extremities. I'm going to have you walk 5 foot that way. And I'm just looking to see that his gait is equal, heel to toe. Right, you can come back. Muscle groups look very symmetrical. No atrophy is noted. That's a good finding. So first I'm going to have you flex your knee, bring it like this, flex and extend. Good. So you can go ahead and take a seat on the bed. I'm going to have you bring your feet in together, point them together, point your toes together, feet apart, good, and then away from each other. Good. So I'm going to check some of the muscle groups as well. You can relax. Okay, try to bring extend at your knees. So bring them up. Good. And back. Good. And up. Good. And down. Good. And then try to move my hands apart. Move my hands together. Good. And all those were very strong and very equal. I'm going to go ahead and have you lay on the bed. Okay, bring your knee to your chest. Good. And down. And bring your foot, try to put it over this way. Any pain?
No.
Good. And we're going to do internal rotation. Good. Go ahead and bring your foot down. All right, I'm going to have you flip over. Checking your hips still. Bring this leg up off the bed. Good. And I'd have you do that on the other side as well, but I'll have you flip back over. I'm going to look at your knees again. Some things that we can do for looking at knee effusion or any fluid that's on the knee. I can do ballottement, which is just checking to see if I put a little pressure above the knee and I press down on the patella. If it feels like it's floating, that might mean that there's fluid under it. Ballotment is also another test. Let me show one side. And then I can see if there's a fluid shift medially, which there is not, but that would also, if I saw the fluid shift, it would indicate any fluid that might be on the knee. Next things I can do to test for any meniscus injury or any ligament injury, I should say. I'm going to do the anterior posterior drawer test. Sit here and bring the tibia to and away from me. You're good, you can relax. And I would notice any extra elasticity. Good. And then the McMurray's test, which tests for meniscus injury. And any pain?
No.
Okay, good. All right, so I'm going to be down here at your feet. I'm going to have you try to bring your feet up towards your head. No, sorry, your toes. And then extend. Good. And then bring them in towards each other. And away. Good. And try to press down on my hands. Good. And back. Okay. Perfect. You can go ahead and sit up. Also going to test for carpal tunnel. So one side is the tensile test. I can tap on the medial nerve. Any pain, numbness, tingling?
No.
Good. And I can have you do the Fallon test where you put your hands together like this. And I would have you hold for a minute, and any numbness or tingling would be an indication of carpal tunnel. Good. So next we're going to move on to the neurological testing. We've already gone through the cranial nerves, and we've done a lot of the musculoskeletal. The one other one we could do that's very common is have you squeeze my fingers. Good. And I'm noticing it's very symmetrical on both sides. His muscle groups are in sync. So the next thing I'm going to do to test for is doing this cerebellar test, and that's going to be testing for upper extremities first, upper extremity coordination. So I'm going to have you take your index finger and touch your nose. And I'll have you do it when you close your eyes. So do that a couple times. Good. Another way to test this, you open your eyes, is touch my index finger and then touch your nose. Good. And I can do that with the other hand as well. Lower extremities, I'll have you take your heel from one foot and run across your shin from your ankle to your knee. Go ahead and run it down your shin. Good, and I would have you do that on the other side as well. So go ahead and stand. This is the Romberg's test. So I'll have you stand, you're stable, I'll have you close your eyes, and I would have you stand here for 30 to 60 seconds. A little swaying is okay, but if he was to lose his balance, that would be a positive Romberg's test and indicate neurological impairment. Another one is pronator drift. I'll have you put your hands out in front of you like this. Good, and I'll have you stand like that for 30 seconds. If he was to droop or lose supination in one side, that would be a positive test and indicate neurological impairment. All right, so go ahead and take a seat, and we'll do the sensory testing. So sensory testing, as we did with cranial nerve 5, it's the soft and the sharp touch. Most of these are done with their eyes closed. So I'll show you what soft feels like, and this is what sharp feels like. I'm going to have you close your eyes. Tell me if it's sharp or soft.
Soft. Sharp. Soft. Sharp.
Good, and I can do that throughout the body and get a good idea on each side. So the next thing I'm going to do is you can tell me which part, if you're feeling 2 touches or 1.
2. 1. 1. 2.
Good. Next one is proprioception. I'm going to have you close your eyes and tell me if this is moving up or down or left or right.
Up. To the right.
Good, and I can do that again throughout his body to get an idea of his proprioception. And one other thing I can do is have him test temperature. Close your eyes, tell me when you feel cold.
Cold. Cold. Cold.
Good. I can also test vibration. Tell me when you feel vibration.
Feel it.
And I can do that on bony prominences to test his feeling of vibration. A couple other tests we can do. I'll have you give me your palm. And this is called stereognosis. I'm going to put a familiar object in your hand, and you're going to please tell me what it is.
Okay. Key.
Good. Other hand.
Pen.
Good. I'm going to draw something on your palm, and you can tell me what it is.
B.
Perfect. So those are all good testing. So that would be how you do the sensory test. From here, I'm going to move on to reflexes. I'm going to do bicep, relax. Okay, a little bit of movement, brachioradialis. A little bit of movement, and then the tricep. A little bit of movement, patella. And the Achilles. And a little bit of movement. All right, so from here, I'm just going to check meningeal irritation. I'm going to have you lie back on the bed. First is Brudzinski's. I'm going to have you have your chin touch your chest. And I'm noting to see that if his knees come up, that would be a positive Brudzinski sign. And I'll have you relax. And then we'll bring your leg up. And I'm going to straighten it. Any pain?
No.
And that would be, and if you had any pain, that would be a positive Kernick sign, and both of those would indicate meningeal irritation. And this concludes our head to toe assessment.